Hello, and welcome to my journal club. My name is Sophia Campbell, and today I would like to talk to you about postnatal depression, or PND. Having a baby should be one of the most exciting and rewarding experiences in a woman's life. However, for around 10 to 20% of women, becoming a mother is associated with dejection, stress, and symptoms of depression. The sudden onset of PND usually occurs in the first 6 months postpartum and generally carries a high burden for sufferers, often going undiagnosed and untreated. Beyond Blue estimated the cost of untreated PND to the community to be $660 million in a period of 20 years. Today we'll be focusing on Janice Goodwin's study, Women's Attitudes, Preferences and Perceived Barriers to Treatment for Perinatal Depression. This study was part of a larger descriptive study based on questionnaires, which was published in 2009 and has 144 citations. The study established 4 key research questions, and these can be seen on the screen. In summary, the study focused on preferences and acceptance of treatment, the perceived barriers to seeking treatment, and lastly, where and from whom would they prefer to receive this treatment from. There is no hypothesis specifically stated in this paper. The study focused on data collection from women during their 3rd trimester of pregnancy. These women were recruited from 2 obstetric clinics in Boston, Massachusetts. The first part of this questionnaire gathered information on demographics, past history of depression and mental health symptoms, current or previous antidepressant use, and psychological stresses. The study employed the Edinburgh Postnatal Depression Scale and 2 ranking tasks. Women were required to number a list from 1 to 3 of the treatments they preferred and the barriers they thought may impact them when seeking this treatment. Lastly, women were required to respond to a range of questions that evaluated acceptability of treatment. A list of these questions can be seen on the screen. 509 women completed the questionnaire with a mean age of 31.6. 22% of these women reported significant levels of depressive symptoms, and 8.6 fell into the probable depression range on the Edinburgh scale. Looking into treatment preferences, 92% of women endorsed individual therapy and 62% accepted group therapy. Statistics showed a steep decline in acceptability of antidepressant medication, reducing from 69% to 33% once one falls pregnant. Women were also more likely to report the taking of antidepressant medication as acceptable if they have done so previously for an existing condition. No time, stigma, and no childcare were rated as the top 3 perceived barriers to treatment and can be seen in Table 5. Most women indicated that they would prefer to receive help at the obstetric clinic, while 22% reported a preference to a mental health specialist. The study consisted of women who were highly educated, older, married, and of a high socioeconomic status. As a result, they may not be representative of other populations or account for women in different geographical locations. Goodman's research extended on previous studies and highlighted the need for acceptable and available interventions. Some of these outcomes are that mental health treatment should be available at obstetric centres, as many women preferred this, providing childcare so that women can attend appointments, educating these women on the help that is available, and finally, cost, transportation, and language barriers need to be addressed. Efforts to reduce stigma and educate women is required on a global scale. Future research into the area of preferences and barriers may lead to improvements in this treatment and ultimately the overall health outcomes of women and their children. Thank you for watching.